Bob, take it away.
All right, Dan, thanks a lot. Thrilled to be back again. And what we're going to do is follow up on some of the testing that you can do when you suspect an inflammatory disorder. So you might say, well, why do I need to hear this presentation? It's all about C-reactive protein. What else do you need to know? Well, yeah, C-reactive protein is a big part of it. But what is C-reactive protein exactly? And why is it such a, quote, famous marker of inflammation? What's it indicating? Well, it's part of an overall response pattern that I talked about this morning called the acute phase response. And basically, it's an illustration of how local inflammation, how you can have local trauma or local exposure to a pathogenic structure, and that can result in a systemic response. And what's mediating that systemic response? Well, it's cytokines, mostly cytokines, not entirely, but for all practical purposes, it's cytokines. Interleukin-6 is the biggie. And for that reason, interleukin-6 is often considered to be a surrogate marker for C-reactive protein. So what happens when all of these cytokines get activated by a local inflammatory response, like gum disease, which I mentioned this morning? Well, the liver goes crazy. It starts making all kinds of proteins, up to 45 grams a day. Think about this. This is clearly a breakdown state. The acute phase response can occur when somebody gets surgery, when they get their gallbladder out. Suddenly they lose weight. Why do they lose weight? Because the liver is just eating up all their proteins, creating these inflammatory mediators. The white blood cell count goes up. You have thrombocytosis, an increased clotting. You get an increase in body temperature from endogenous pyrogens. You get activation of NF-kappa B. And as I said, you shift to an overall catabolic state. The acute phase response is one heck of a way to lose weight. I wouldn't recommend it, but it does happen. And what are three of the top markers that we know about? C-reactive protein can go up 100 times in 24 to 48 hours after an acute stress, like an infection or an injury. Another one, which is a really good one, serum amyloid A, is one that it baffles me why labs don't offer this. I know very few national labs that offer this as a standalone test. It is part of some profiles. I'll show you one during the case studies on Sunday. Plasma glutathione also can go up. So if you're measuring glutathione during the acute phase, you might be thrown off because it looks like the person's got more than adequate glutathione, but actually it's a response pattern. It's not an indicator of glutathione stores. So you get a rapid increase in CRP, and then you get a slow increase over weeks of fibrinogen, prothrombin, which are obviously going to contribute to clotting. Complement is going to go up. The liver is going to be making more complement. Transport proteins like ferritin and ceruloplasmin are going to go up. So again, this can fool you if you're checking for iron deficiency or copper deficiency. You might say, well, that ferritin level is up, ceruloplasmin level is up. Well, it looks like there's plenty of iron or copper around, but maybe not if it's part of the acute phase response. At the same time that the liver's making all these proteins, it's also diverting amino acids from other proteins to make those proteins like fibrinogen. So you get a drop in albumin, transferrin, the vitamin A retinol binding protein, alpha fetoprotein, IGF-1, thyroid binding globulin. So you can see how this can wreak havoc with hormonal metabolism. You also get a decrease in plasma iron and zinc. You can measure TGF-beta. It's a standard cytokine, but it can be a little bit confusing, as I will show you later. What does that mean? TGF-beta is involved in shutting off this acute phase response. So it indicates the immune system is activated. It's trying to do something. So yes, you can measure it, but it's not always clear what exactly you're measuring. So I showed you this picture this morning. You see at the top an inflammatory stimulus. It activates this acute inflammatory response. So a person gets gum disease, they get gingivitis, they have a local increase in cytokine production. Those cytokines can then go all kinds of places in the body. They can go to the bone marrow, increase leukocytosis. They can go to the liver, increase C-reactive protein. They can go to the brain, increase fever, or affect the hypothalamus to increase cortisol. So kind of classic scenario is a patient who's got elevated C-reactive protein. You're not sure why. You look in their mouth, and you wish that you had not looked in their mouth, because what do you see in there? You see bad gum disease. And I've seen this over and over again. I tell the person, go see your hygienist, get your mouth cleaned out, and their C-reactive protein comes down. And no question that there's that relationship. So here's a diagram of what that looks like over 7 days after an inflammatory stimulus. CRP, serum amyloid A, both go way up within that first week. And then over a period of weeks, fibrinogen goes up, haptoglobin goes up, but at the same time, albumin goes down. So what kind of things can activate acute phase proteins? What's a mild activator? Strenuous exercise. So tell your patients, don't run to the lab to get your blood drawn, because that short burst of exercise on the way to the lab can make your CRP go up. Other things that can make it go up: emotional stress, chronic psychological illnesses, and I'll show you an example of that later, childbirth, heat stroke, all these things can make CRP go up, and that means they're making interleukin-6 go up as well. Where do you get big time increases in C-reactive protein and other inflammatory markers? Well, infection. Classic one is pneumococcal pneumonia, and I'll cover that in a minute. Any kind of trauma or surgery. Can an ankle sprain make your CRP go up? You bet it can. Seen that happen. Myocardial infarction can do it, or any kind of acute ischemic damage. Inflammatory diseases, inflammatory bowel disease, for example, can make it go up. Now, why don't you see it go up with things like Alzheimer's disease? It kind of stands to reason that it might, but when you get these slow, smoldering inflammatory diseases like that, it doesn't always get mediated through cytokines. So CRP and some of these other markers we're going to talk about, they're not the be all and the end all. It's not all inflammatory diseases, but certain ones very consistently will see an increase in acute phase proteins. So will advanced cancers, but milder cancers, even metastatic cancers, don't always cause an acute phase response. So CRP is kind of the classic acute phase reactant. It can go up 10,000-fold in response to injury and infection. Now, what causes CRP to go up and then never completely come back down again? Chronic inflammatory conditions, right? You could almost call this, and it sounds odd, but you could call it the chronic acute phase. Chronic acute phase reaction that's going on. And why do you get that? Well, for some reason, the person's immune system doesn't turn off that acute inflammatory response. Okay? So it's a failure of counter-regulatory mechanisms, or perhaps a persistence of the inflammatory trigger, a persistence of the gum disease, or adipose tissue. Excessive adipose tissue can do this as well. And what do you see with this chronic acute phase response is mild to moderate elevations of acute phase reactants. So mild to moderate elevation of highly sensitive C-reactive protein. It's simply called highly sensitive C-reactive protein because you need a better assay, not a different assay, just a more sensitive assay to look for small changes so you can distinguish between levels of 1, 2, and 3 versus levels of 5, 10, 15, or 20. Something you may not have thought about is that elevated white blood cells are actually part of the acute phase response. So I showed you that diagram earlier. You get an activation of cytokines that then go to the bone marrow and increase leukocytosis. Well, before talking about that, let's talk about the whole spectrum of how to interpret the white blood cell count, because before we can start talking about an elevated count, we got to know what a low count is. And what does a low count mean? A low count is not part of the acute phase response. It's an indication of something going on with the bone marrow. So what are we talking about with leukopenia? That's a white count of less than 4,300. Now, I will tell you right off, I have seen more patients than I can count that show up with a white blood count of 3,000, 3,500 that are otherwise healthy. They're otherwise healthy. So don't freak out if you see this. I have sent a number of these patients to a hematologist who basically scratches his head and says, why did you refer this patient? I see patients who have a white count of 1,500 or 2,000 all the time. I'm not worried about it. And a lot of times they'll simply repeat the CBC in their office and everything will be fine. So the important thing is the downward trend more than the absolute number. Now, obviously, when you're down around 2,000, 2,500, you do worry that something's going on. What are the most common causes of these acute drops? Usually it's a viral infection, especially HIV, herpes, so you need to do more of a workup there. Hepatitis can do it. More rarely, folic acid deficiency, B12, or copper deficiency. I can't honestly tell you that I've ever seen that in my practice. I still check for these things with leukopenia, just in case, but I have not seen that commonly. I'm sure it exists, but just not in my particular clinical practice. What I do see relatively commonly is the effect of drugs on the white count. And I would say the number one category for people with chronic leukopenia, especially neutropenia, is people that have gotten cancer chemotherapy. And these are people, I'm sure you've all seen them, who have gone through successful treatment for cancer and their white count stays low for years afterwards. As I'll talk about later, what I'm particularly concerned about in that scenario is that their natural killer cells are low as well. So that's something you would do as a follow-up. Other drugs that can do it, antibiotics, anticonvulsants. The classic anticonvulsant is carbamazepine that can do it. So can valproic acid, antithyroid medicines like PTU, certain antidepressants and antipsychotic, anti-inflammatories. Basically, any drug that you can think of can knock out the white count in susceptible individuals. So always think about pharmaceuticals, medications when you see that persistently low white count. Now let's switch gears and talk about leukocytosis. Here is a long-term patient of mine. You can see this is from back in 2013. Still working with this patient and he's doing well, but maybe that's a little bit of a tip-off. Normally when you see a white count like this of 11,900, you think, oh my gosh, something is wrong. And which fraction of his white cells is up? Neutrophils. So he's got a neutrophilia. A neutrophilia. So he was 11,900. The previous lab was 11,600. Well, that's a source of concern. Something is going on. So let's wait, check it again in a couple of weeks. It's gone up 12,130. And it's still a neutrophilia. Is there anything else I might want to get on this patient? How about a C-reactive protein? Oh my, look at that. The C-reactive protein on November 6th is 54. The one before that was 64. The one after that was again 64. There's no doubt that's a high CRP. What's going on? He's got leukocytosis and C-reactive protein. Well, he's got ulcerative colitis. He's got ulcerative colitis. And at the time, it was not that well controlled. We were working with a lot of different medications, and we were trying to see if we were able to cool off his inflammation. Obviously, at the time, we're not. I can tell you that we are now, and that he's doing much better. So what I do now in this particular patient is I get a CBC and a CRP on him once a month, cheap and easy. That's the best thing about CRP. Cheap and easy. You can do it on a regular basis, and it can predict a flare. Why would I want to know that? Because if he's starting to flare, I might be more aggressive with my treatment protocol. So a white count over 11,000 indicates the acute phase response. There's activation going on. Okay? You're also going to wonder, well, is there inflammation or infection? Could this be some kind of weird allergic reaction to a drug? Now, if you look at the subclass of white cells, the kind of classic way to interpret them is to say neutrophilia means bacterial. Except with COVID-19, what are we seeing? Sometimes you'll see a severe neutrophilia. The neutrophils will be way high with COVID. So that kind of throws that old adage out the window. In general, though, we would think that a viral infection makes your lymphocytes go up. Any kind of infection or inflammation, monocytes, allergies and parasites, eosinophilia. I've certainly seen that when I spent a little time working in Africa, where I saw a lot of people with parasitic infections could have super high eosinophil counts, absolute eosinophil counts. Other scenarios that make it go up: malignancy, especially leukemia, obesity. We're going to talk about this in a little more detail, because this is where it gets really interesting in using the WBC as a marker. Acute stress can do it. Check it after a seizure, that it can go up. Or if a person is on lithium, certainly seen that, put a patient on lithium for bipolar disorder and have it go up. Steroids can make the white count go up, almost paradoxically. Yeah, it's an immune suppressant, but it makes these white cells demarginate. Here's the clinical pearl, and the reason for talking about this so early on is that elevations of the white count in the top quartile can predict an increased risk of cardiovascular disease. Just like highly sensitive CRP, an elevated WBC is not something you want to ignore. It can indicate that something is going on. Now, there are a number of studies that show this. One of the best was the Women's Health International study. 72,000 women post-menopause, 40 clinical centers. They didn't have cancer. They didn't have heart disease. They were followed for over 6 years. And what it was found is that women in the upper quartile of the white count had a 40% higher risk for non-fatal AMI and a 46% higher risk for stroke, plus a 50% higher risk of total mortality. So this cheap, easy, ubiquitous test is an independent predictor of cardiovascular disease and mortality, comparable to CRP. So the two of them go really well together. I think you should almost be in the habit of measuring these. Even if you're not thinking about an infection, you should still get a CBC. Even when you're not thinking about anemia, it's useful in a lot of other regards. This is a paper that I wanted to come back to because I think it's very interesting. Leukocytosis in obesity. Well, that makes sense, doesn't it? Adipose tissue is inflammatory. It generates inflammatory cytokines, adipokines. So when you're generating these inflammatory cytokines, then you're having an impact on the bone marrow, and that makes the white count go up. An interesting study actually looked at all causes of neutrophilia and attributed relative percentages for what might cause it. The number one cause was cigarette smoking, and obesity was number two. Idiopathic, I've diagnosed that a few times. I'm sure that some of you have diagnosed idiopathic as well. And I've also diagnosed idiopathic inflammatory. I was really proud of myself. You have idiopathic inflammatory. Okay, I'm joking, but what I'm saying is that that elevated white count can be a meaningful marker. Don't discount it. Yes, it's simple, cheap, and easy, but there's a lot of value in tracking that. Now, how many of you still measure the erythrocyte sedimentation rate? I bet a lot of you think, hey, that's kind of an outmoded, outdated test. You can always do CRP instead. There's no value of a sed rate over CRP. I disagree. I think especially early in the course of a potential inflammatory disease, you can see an elevated SED rate. So, and it's cheap and it's easy. Why not do it really regularly, at least for initial screening? What causes the SED rate to go up? It's rouleau formation. So when there are proteins in the bloodstream that make erythrocytes sticky, then you put that blood in a column and the red cells will stick together, plump, form a rouleau, and they will fall more rapidly. So what are the two main proteins that do this? Fibrinogen and immunoglobulin G, IgG. So when there's something that's elevating the level of those acute phase reactants, then you'll get this rouleau formation. So yeah, it's a secondary marker, right? It's a surrogate marker for fibrinogen, but it's a lot cheaper than fibrinogen, easier to do. It's a lot cheaper than measuring immunoglobulins. So I keep coming back to this: cheap, simple, easy to do. Now, there's problems with the SED rate, I'll admit. Sometimes you can see it go up in non-inflammatory states like anemia. It's non-specific and it's imprecise. It's very slow to rise and fall. Why is that? I showed you that diagram earlier. Fibrinogen doesn't really start going up for a week or 2 or 3 after an inflammatory stimulus. So it's not a quick indicator of something that's going on, but it's still helpful in somebody for whom you're suspecting an inflammatory disorder. Where do you see low SED rates? Polycythemia, sometimes with leukocytosis. People that have sickle cell anemia can have a low SED rate. Or if you have low plasma proteins, you're not having those proteins around that make the red cells sticky and clumpy. High SED rate, inflammation, infection, autoimmunity, in particular, the autoimmune disease called polymyalgia rheumatica, which I've seen diagnosed a number of times in my practice. That's a scenario where you really don't want to miss that high SED rate because it can be super high. With PMR, polymyalgia rheumatica, you can see a SED rate 120. And of course, when you see that kind of SED rate in polymyalgia rheumatica, especially if the person is having pain in their temporal muscles, then you worry about temporal arteritis, which can lead to blindness. So the SED rate is a tip-off that you should be worried about that particular patient, and probably send them to an ophthalmologist. Other scenarios where SED rate can go up: lupus, RA, inflammatory bowel disease, multiple myeloma, Hodgkin's, chronic kidney disease. Just a comment, it's a little hard to predict with these patients with autoimmune disease whether they're going to be a high SED rater. I'll call them that, a high SED rater. Some people with lupus don't have a high SED rate and they have a high CRP, or the other way around. Same thing with rheumatoid arthritis. That tells me that there's more subtleties going on with this acute phase response than we completely understand right now. And that's the reason for getting both the SED rate and the CRP. One reason you want to do it, person's got a lot of, say, respiratory symptoms, nasal symptoms, lung symptoms, and you're wondering, is this an inflammatory condition or is it allergic? You shouldn't see the SED rate going up with allergy. What about a person who's got a persistent bone pain and you're worried about osteomyelitis, or a woman with pelvic pain where you're worried about PID, or somebody who's coughing a lot, short of breath over a long period of time, you're worried about TB, the SED rate can be helpful in that regard. So I hope I'm making the case to you not to throw out the SED rate, again, especially as an initial screen. So back to CRP, what is it? Well, it's an acute phase marker, but it also contributes to inflammation. The C-reactive protein activates complement. We'll talk a little bit more about what complement is in a minute, but it participates in the inflammatory response. So having a high CRP is not just something that you're using as an indicator, surrogate marker. It actually tells you that you need to be a little more aggressive in your treatment program. That CRP can damage heart tissue. It can enhance coagulation. And it can bind to LDL, so it contributes to atherosclerosis. Where did the name come from? It binds to C polysaccharide, which is made by pneumococcal pneumonia. So that's kind of the classic scenario where CRP is up. A person with pneumococcal pneumonia, their CRP can go up into the thousands, can go super high in a short period of time. And as I've already mentioned, it's a surrogate marker for interleukin-6. Now, there are other inflammatory cytokines involved in the acute phase, so CRP doesn't always go up. But it does fairly consistently. The levels go up and down pretty quickly. So if you're getting inflammation under control, then the CRP should go down. Now, the kind of amazing finding is that you can have these low but still elevated increases in highly sensitive CRP that go up with inflammatory conditions like increased body mass index and cigarette smoking. So now let's go to a polling question. What are the indications of C-reactive protein? So just throw out some ideas. Metabolic syndrome, absolutely. Inflammatory bowel disease, absolutely. Obesity, absolutely. You're getting this pretty wide range. Type 2 diabetes, yes. On that continuum with metabolic syndrome. Okay. Autoimmune disease, so now we're really getting a lot of them. Any kind of inflammation, yes. Fatigue, that's a really good point. Fatigue, gingivitis. Food allergy, not so much. Not so much. It can if that allergy is causing a pretty significant inflammatory disease. So yeah, we're seeing a pretty good range of conditions here. So let's move on and talk about the list that I have. Actually, I'm going to go one slide forward. Sorry, I seem to be missing the slide I was looking for. So let's just talk about when you do a CRP versus a highly sensitive CRP. So mainly we use the highly sensitive, or some labs call it cardio CRP, as a cardiac risk marker. And that's because it can be elevated for a prolonged period of time before a person has an event, and it is independent of measuring LDL cholesterol, lipoprotein little a, et cetera. So it's very good for stratifying cardiac risk. But I also think that it's not just for CVD. It tells you that there's some low-level inflammation going on that you need to deal with. Where do you use regular CRP? Well, you've already listed a lot of these things. Rheumatoid arthritis, lupus, vasculitis, inflammatory bowel disease, some cancers, especially in the latter stages of cancer. MI, I wouldn't use this as my only marker for MI. Pregnancy, I'm not sure what point you'd be making. Yeah, look, your CRP's up, you're pregnant. But oral contraceptives can do it, and that kind of goes along with the hypercoagulability that you see. So when you've got a high level, if you're just doing a regular CRP, the problem is the cutoff. Some labs, if you're doing a regular CRP, if it's less than 5, some labs say even less than 10, then they don't even measure it. And that's why you need to get the HSCRP. If you're getting the HSCRP in a more questionable scenario in the first place, then you should be able to determine whether it's higher. I can tell you my own scenario. I was going in for a cardiac panel one day for a blood test, and that morning I woke up with acute left lower quadrant pain. And I thought, well, that's kind of weird. It wasn't terrible pain, but it was bothersome. Got my blood tested. My CRP came back 50. And I subsequently realized that I'd had an attack of diverticulitis. So that was a very interesting scenario to me. Is I went in looking for one thing for my cardiovascular risk, and I found out I had an inflammatory scenario. So, we could probably spend a long time debating about which one to start with, the HSCRP or the CRP. The patient I told you about with IBD, I'm just doing a regular CRP because has tended to run between 10 and 50. More recently, now that his colitis is completely controlled, he's running a 9 or an 8, but there's no point in doing an hsCRP because he's going to be out of that range of greater than 3 milligrams per liter. So hsCRP, when you're not really expecting to find a big hit, you're looking for subtle inflammation, metabolic conditions, chronic low-level inflammation. That's when you do the hsCRP. So who are we testing? People with stable coronary artery disease or at risk of that, somebody with angina, person that's had cabbage surgery, maybe a person with atrial fibrillation, somebody with type 2 diabetes, or we're saying people with these conditions. How about somebody at risk of getting these conditions? So I see it more for risk factor stratification. It might help me decide whether they need to be on a statin therapy. If they got a super high LDL cholesterol and a high hsCRP, then I might want to go with a medication over dietary therapy, etc. So what are the limitations? Is that people with cancer can have a normal level. People with lupus, as I've already mentioned, can have a normal level. They may only have an elevated SED rate. So all kinds of inflammation don't drive up the CRP. It can be blunted with liver disease. So you need to make the proteins. You need to have proteins to do this. If a person is protein deficient, they're going to be in trouble. They're not going to make it. So why CRP versus SED rate? The CRP is more precise. We have this highly sensitive CRP, which is better for risk prediction. CRP doesn't go up with age like the SED rate does. It's a really good marker for rheumatoid arthritis for prognostic value. And you have this broad range of abnormal values. If you've got a CRP over 100, that's probably not an inflammatory disorder. That's probably some kind of infection. Okay, another polling question. What are true statements regarding SED rate? SED rates increased in local and systemic inflammation, yes or no? Helps to distinguish inflammatory versus allergic, yes or no? Rapidly rise and fall, yes or no? May be elevated in non-inflammatory states. So yeah, I think people are getting it. Yes, local and systemic inflammation can raise the SED rate. You tend to see it a little bit more elevated with systemic inflammation, but you do see both. Yes, you can use the SED rate to distinguish allergy or not. Yep. The SED rates rise and fall. The answer is no. This is a slow reactant. Goes up over 1, 2, 3 weeks. So it's good for a chronic inflammatory disorder, but not so much for an acute disorder. Can you see the SED rate go up with non-inflammatory states? Yes. So it can be a little bit misleading in that regard. So I think you're getting the general impression here. What are the following true statements regarding C-reactive protein? Does it increase with age? Yes or no? Does it go up with smoking? Does it bind to LDL cholesterol? Can it go up 10,000 times? So the answer to the first one is CRP does not go up with age. SED rate does. So that's why CRP is distinguished between the two. CRP can go up with smoking. Smoking is one of the most inflammatory things that you can do. CRP binds to LDL. Yes, that's how it contributes with atherosclerosis. And with injury and infection, whether we're talking about gum disease or an ankle sprain, plasma levels can go way up. Absolutely, no question about it. So thanks for trying. Now, what about fibrinogen? Why not just measure fibrinogen instead of sed rate? Some people would argue that fibrinogen is a little bit more precise and a little bit more accurate because the sed rate is, as I said, a surrogate marker. Yeah, fibrinogen, it's a little bit more expensive. You don't always get good insurance coverage for it, but it still can be helpful. I mostly use it as part of an overall cardiac panel when I want to know if the person is at risk for blood clots. That's the number one scenario. Are they at risk for more clotting? Obviously, if they've already got atherosclerosis, if their LDL cholesterol is up and their fibrinogen is up as well, then you need to be addressing that situation. And mostly what I do, to be honest, is I use fish oil and sometimes bromelain, which is an enzyme from pineapple stems that helps with excessive coagulation. So those are my typical responses to an elevated fibrinogen, understanding that I'm not just treating the marker. I want to know why it's up in the first place. Why is there inflammation going up? Here you can see just a reminder that you get an inflammatory stimulus, that CRP goes way up in a short period of time, within days, thousands of times. The fibrinogen is a slow marker, right? So it's not so much something you're going to measure after an ankle sprain. It's better to look at this in somebody who, say, has a chronic inflammatory disorder and you're wondering about their clotting risk. One of the things that we know about certain inflammatory disorders, cancer, for example, a person with chronic cancer is more at risk of having blood clots, more at risk of having blood clots. I've already mentioned this, but just to remind you, half-life of fibrinogen is days, half-life of CRP is hours, half-life of sed rate is days to weeks, So we have fast markers and slow markers. The CRP goes up quickly, fibrinogen and sed rate go up slowly. Let's talk a little bit about complement. Now, a lot of people learn about complement in school and then wish that they never had to hear about it again because it's a really complicated thing. Complement is complicated, or it seems complicated. But what is it really? It's not that complicated. All the different reactions involved are complicated, but all complement is a bunch of big proteins in circulation in the bloodstream that are part of the innate immune response to exposure to pathogenic structures. So PAMPs, as I've mentioned, PAMPs can activate complement and immune complexes. Those are the two things I want you to remember. Pathogen-associated molecular patterns and immune complexes can activate complement. And when you activate complement, it splits apart. It splits into fragments. And those fragments are highly inflammatory. So you go from these inert large proteins to these inflammatory fragments. So here we see on the left, the kind of classic three pathways. The one that most people are familiar with is the antigen antibody complexes. So when, if a person is having an immune response, and the best known example of this is in lupus, the antigen antibody complexes will react with C3. C3 breaks up into C3A and C3B, split products, and then those will recruit neutrophils and monocytes. Okay, so we're going to get activation of other innate immune cells, and that's going to turn on the whole cascade process. So generally with the acute phase response, you increase production of complement. So that's interesting. Complement levels will go up as a result of inflammation. But in immune complex diseases like lupus, where you get a lot of immune complexes in the bloodstream, you actually chew up that C3 and C4. So you will see low levels of C3 and C4. That's why C3 and C4 are kind of classic markers for lupus, along with the anti-nuclear antibody. If you see low levels of the hemolytic complement CH50, C3 or C4, that's indirect evidence of consumption due to immune complexes. That's sometimes measure general immune complexes, but measuring low complement can be just as informative because it looks at the functional result of having excessive immune complexes. The important take-home message is, where are you going to check C3 and C4? And sometimes CH50. I don't check it that often, but C3 and C4, I check fairly regularly. You see that in lupus, you see it in vasculitis, you see it in kidney disease, or you sometimes see it with a hereditary deficiency. There is this one scenario called hereditary angioedema. That's when a person gets sudden swelling of their lips or the uvula. This can be actually life-threatening. Sometimes you can actually have swelling of the peritoneal membranes causing abdominal pain. So hereditary angioedema can cause a wide range of sudden onset of syndromes. And what's happening with hereditary angioedema is it's a lack of an inhibitor that's basically stopping the complement cascade. So if you're lacking this inhibitor called the C1 esterase inhibitor, and you can test for this in the lab, you have to get C1 esterase inhibitor function, not just measuring the level, but you have to measure the function. It's a readily available test. So if you think you got a patient with HAE, hereditary angioedema, useful thing. What's going on here with hereditary angioedema is their C4 levels are getting chewed up because of that complement activation. So they're going to have low levels of C4. So lupus is kind of the classic disease where you're going to measure C3 and C4. And in some patients, it's going to be low. And other patients, even with bona fide confirmed lupus, it's completely normal. Again, this speaks to the heterogeneity of the inflammatory response. So you do it early on in a patient with active disease. And if those levels are normal, then there's no point really in continuing to do them. But if they're low, you can use them to follow the patient over time. That's the main value of these. Now, why not just measure the split products? Well, I do this sometimes. These are called anaphylatoxins, complement split products. So especially if C3 is low, C4 is low, that implies the split products are going to be high. And I do see that. I've seen that a number of times. Why would you want to know about this? Because these guys are pretty significant inflammatory mediators. They're involved in bronchospasm, tissue granulation, vascular permeability, part of the classic inflammatory response. They generate free radicals. So these are nasty fellows. If they're up, then they tell you the immune system is really activated. Well, why not just do them all the time? Because it's expensive to do them, and you've got to handle the specimen exactly correctly. If you don't, then complement can break up on its own. So when you do a normal, I think it's a lavender top, when you do this in the lab, if it's not transported correctly, don't quote me on that particular form of tube. All I know is that I've had a few patients that had elevated anaphylatoxins, and then when they actually went down to a facility that measured them, National Jewish Hospital, and had it drawn on the spot, the level was normal. So you've got to be really careful that the person handling the blood specimen knows what they're doing. What are some scenarios where they might be really pathognomonic? Dr. Schultz is going to talk about this in some detail, but there's at least one published paper showing that split products are elevated in chronic Lyme disease. C3A in particular is also increased with acute Lyme as well. We desperately need good markers for Lyme disease because what appears to be chronic Lyme can be mimicked by a number of other illnesses as well. So elevated C3A and C4A can be a clue that you're going down the right path. I've also seen it elevated in lupus. I've seen C3A and C4A elevated with lupus. I've seen C4A increased with chronic fatigue syndrome. Now, you might say, well, what does that mean? What does that tell us about the pathology of chronic fatigue? Don't know. All I can tell you is that I've seen it. It's in the literature, and it tells you that inflammation is somehow being activated in this particular scenario. So this is not your first line of testing. This is not even your second line of testing. Again, because it's expensive and you have to handle the blood just right. But it can be really useful for your confusing patient